So, good morning. My name is Prathap. I normally stand when I talk, but I've been asked to sit, feel a little constrained. But anyway, so what I hope to cover this morning with you is to help you to appreciate the importance of having reliable evidence to improve health outcomes through your decisions. And I'd like you to understand in a little way how appropriate study designs are required if you want to generate reliable evidence. And I want to be able to help you understand the difference between statistical significance and clinically important results. Because we're all clinicians, and what you read is mostly about statistical significance. Now, you need to be able to figure out what is going to be clinically important to you. Then, also to understand what you mean by internal validity and external validity. And finally, to appreciate the role of evidence synthesis in generating the evidence that you need, which is reliable, so that you can make informed health decisions. And I'll use two case studies, one from neonatology and the other from infectious diseases to illustrate some of these points. Now, you all heard of this term evidence-based medicine, which was coined by these two guys, Gordon Guyatt and Dave Sackett. They both were in McMaster University in Canada at this time. Dave Sackett then moved to Oxford, and they defined evidence-based medicine as the integration of research evidence, clinical expertise, and patient values, which means a clinician is at the center of evidence-based medicine, but the clinician needs to be able to obtain and understand what is reliable evidence to answer the question, and then be able to get the views of their patients to see whether they should use this. So that's the whole purpose of this approach. Maybe a good time then to start asking you, what do you think is research evidence? Can anyone define what is research?
Research is something to search for the truth.
Okay, I'm glad you said that. You say that you're searching for the truth. If you look at the common definitions, it's defined as an attempt to derive generalizable new knowledge, which will confirm or refute existing knowledge. And you will do this by addressing clearly defined questions or hypotheses and using very rigorous and systematic scientific methods. Okay, that's the accepted definition of what is research. Are you happy with this? You don't have to be happy with whatever is accepted. What do you think is missing in this?
Something.
It may not be accurate. I mean, it's generalizable, but may not be correct.
To confirm or refute. I mean, in that is implicit is that you're confirming something or you're saying it does not there. What I find is a problem is that it doesn't tell you why are you doing research. Because if you don't define the purposes of why you're doing research, you'll end up with this. What is this? The dock of doctors on trial at Nuremberg after World War II. Remember, Nazi Germany at that time was the first country in the world to come up with an ethical statement for research. And they had a very clear hypothesis. There is a nation, a group of people who are genetically inferior to everybody. And in order to exterminate them, they subjected them to a lot of research on how to face torture, cold, extreme climates. So they did it in the name of research, but that's really not the research we need. No? So I'd like to redefine research as an attempt, of course, to derive generalizable new knowledge or confirm or refute existing knowledge in order to understand the human condition, which is why we do basic science research, epidemiological research, and normative research. We want to understand who we are and the methods to maximize human potential, which is why we do analytical research, translational research, health systems research, and qualitative research. And we do this by addressing clearly defined questions and using systematic and rigorous methods. So this is the way I'd like to think of why we do research. Now, what's the big difference between scientific evidence and faith? We live in a country where faith is extremely important to hundreds of people, right? In fact, if you suddenly, God forbid, find out that you've got aggressive acute myeloid leukemia, you're most likely going to fall on your knees and pray. Right? So what's the big difference between scientific evidence and faith?
It's not a question.
Some people will say faith is believing without having the need for evidence. I actually think there are a lot of similarities in the way that what scientific people are trying to do and what people of faith or philosophers are trying to do. We are asking the same quintessential questions. Who are we? Where do we come from? People of science use the methods of science. What are we doing here? People of science use the methods of science. And there's another question, where do we go from here, that philosophers and people of faith think in different ways from scientists. We are clear that they're going to destroy this planet, which is why we've invented astronomy, rocket science, and stuff. We're going to go to Mars. Don't tell me they spend so much money sending our vessels to Mars if we don't have plans to go and live there. So the last question is, who's going to clean up after us? So people of science have invented methods to try and understand what's going on, cleaning up after us, right? So there are lots of similarities, but in science, for scientific evidence, we use different methods and require different levels of evidence to be sure of what we are saying. So it's not that people of faith don't have evidence. Their evidence is a more personal sort of evidence. This evidence is meant to be generalizable. Right. So what I'm trying to drive at is scientific research is actually meant to be a sacred activity. And there was a time when scientific researchers are considered seekers of the truth. And in that tradition, integrity in research is critical. Okay. Now let me ask you this question. Do scientists need faith? I think you do, but not in the way that you're talking about. Because one thing, how many of you are structural engineers? None. Do you know that you're sitting on the second, third floor of a building that you have faith that is not going to fall down? Then you drive from here to Bangalore at 140 kilometers an hour. You have tremendous faith in your German or Japanese or Korean engineering without understanding what is under that hood. So scientific evidence and research is largely based on trust or faith in the integrity of researchers, the informed consent process, ethical review boards and processes, ethical conduct and reporting of research, the peer review process, the editorial process, readers' comments. But the sad truth is, there is so much poor research. Doug Altman was one of the big statisticians of the Cochrane collaboration in 1994. Just when the collaboration started, he wrote this in the British Medical Journal. He said, we need less research, better research, and research done for the right reasons. And he raises the question of what would you think about a doctor who uses the wrong treatment, either willfully or through ignorance, or uses the right treatment wrongly? Most people will say this is unethical and unforgivable. But then we don't say that much about all the research papers which have researchers who use the wrong techniques, either willfully or through ignorance, use the right techniques wrongly, misinterpret their results, report their results selectively, cite the literature selectively, and draw unjustified conclusions. And he calls this a scandal. So the question for us is, looking at evidence-based medicine, can you trust the evidence? And if you read this article by John Ioannidis, he will argue that most claimed research findings are false. And I elaborated on this for an article with the Indian Journal of Medical Ethics to teach ethics committees that science and ethics are inseparable. You can have a study which is ethically sound, but scientifically is of no use. That is unethical. So what happens is that we need to understand that there are a lot of conflicts of interest, not only commercial, academic. Academic societies sometimes get entrenched into certain positions because of senior authors, and they will prevent anyone from changing that point. You keep that in mind. So a lot of unnecessary research is done, inappropriately, poorly designed, and poorly reported research. And there are many studies which are manipulated from the outset by the choice of comparators or the outcomes that they are using. And very often statistics is manipulated. You can ask any statistician, they'll tell you how easy it is to manipulate statistics. And there is a lot of over-reliance on p-values. And I'll elaborate on that more. There's a lot of selective reporting of studies. Only people often report studies which are statistically significant and favor their results. Or even the results, outcomes are changed. Primary outcome will become secondary outcome. Secondary outcome, because it's statistically significant, becomes primary outcome. A lot of manipulation of reporting. And this thing called ghostwriting. Do you know what ghostwriting is? I used to think it was when you have a senior author who did nothing but demands authorship. What I discovered, this is a public relations company who wrote the paper with the author's names prominent people. The ghost doesn't even appear anywhere in this publication, and it's fairly common. And the other issue is manufacturing of disease. Can you give me an example of disease mongering, creating diseases? I'll give you an example.
You keep the cutoffs of
Absolutely. When I studied medicine, the cutoff for diabetes, for hypertension, and all, and hyperlipidemia were way higher than what they are today. So the belief is that when the drug companies saturated their market, they needed new customers. So they got the scientific community to think in terms of pre-diabetes, pre-hypertension, and define cutoffs for that. But what we found is when you treat all these pre-diabetics, because their risk of getting their bad outcomes is low, these drugs that you use to treat actual diabetics don't really work there. So this is an example of disease mongering. If you're interested in this, you go to PLOSMED and you'll find on their website a whole blog full of disease mongering examples. So there is a lot of over prescription of drugs because it is commercially useful. And a lot of marketing of products designed as education. Right? For example, you will find on your table, most of you will have received at least one copy of an NEJM article. Right? Some seminal NEJM article. Most NEJM articles that are citable are drug company, multi-center trials. Right? And the NEJM is run financially entirely on the money that drug companies pay to buy thousands and thousands and thousands of copy reprints of that article. This is what Maria Engel, who was the former editor of the NEJM, wrote, The Truth About Drug Companies. And why do they buy it? To come and give it to you. And this is considered education, but this is marketing. Similarly, many phase 4 trials are done purely to create brand loyalty, not necessarily to observe what the long-term effects are. This is from internal memos from drug companies discussing this, that we have to create brand loyalty. So if I give you, or many of your patients, a particular drug, after you finish that period, they'll buy that same drug because they've got used to it, right? So all of this leads to unreliable publications, and when you use it in practice, suboptimal health outcomes. That is a problem. And the other problem is that of relevance. So Ian Chalmers, who founded the Cochrane collaboration, and many of his co-authors, they published in Lancet in 2014 a very revealing article where they took high-impact journals and divided their articles into 4 quadrants. On one axis is research relevant to advancing knowledge. And on the other axis is research relevant to immediate application. So one quadrant per article which clearly advanced science. On the other end, you had a quadrant which was clearly practically immediately applicable. And then you had a quadrant which was did both. But the majority of publications, 85% of them, they believe, it falls into the waste quadrant where it neither advances scientific knowledge nor does it have practical applications. And why? Because of the pressure to publish. So people publish stuff because they have to, not because it advances science or it has any practical application. And the other problem is all the misconduct that takes place. And it's not only in foreign countries, it's all over. India is very, very common. Lots and lots of reports of plagiarism from the highest institutions in the country. So the problem is research misconduct harms patients, distorts the evidence base, misdirects research effort, wastes funds, and erodes trust in science from the public. So this is the world that you have inherited. And you also inherited another problem over the past few years, this whole thing about what people consider as reliable sources of evidence, right? Many people will consider what they get on their WhatsApp feed as evidence. So you have this whole situation of fake news and alternative news. So even if you give them a scientific study, they won't believe it because their source and their belief systems come from some other source. Okay, which is a tragedy because when you really need evidence, you may not find it. You get caught up in these political battles about hydroxychloroquine in COVID. Right? So clinicians somehow have to make sense of all of this because we are the gatekeepers between patients and all that happens in the name of research. Okay. So what we need, reliable evidence to inform health decisions and give better health outcomes, is we need evidence that is relevant. So you need to start with a focused clinical question, and then you need to find studies addressing this question. And these studies should have used appropriate designs and report their results in a way that you can trust their results. And then you need to have evidence that is evaluated, not just blindly read, not just the abstract and conclusions, but you evaluate the, first of all, do you have all the studies which have answered the question, or do you only have one or two? Somebody gave it to you. Why? Because they wanted you to read it. What about the ones that you didn't find? If you include all of that, you'll get a totally different picture. Then you have to also see the methods. Was it done in a way that the results are reliable? So what is the risk of bias in each of those studies? And then you look at the results and say, I am not only interested in p-value less than 0.05. I want to know how many people will benefit if I use this intervention. The clinical importance of it. Finally, you need to know the evidence that is synthesized. So when you get all these results and put it together to see what is the overall answer, you need to be able to say that this overall answer from all the studies for this outcome is clinically important. I can trust this. And moreover, the results are consistent. It's not that one study says the opposite of what the other study says. And finally, can I contextualize it to my setting from what is in a research setting? So we need to develop the skills to do all of this. And it's possible if you start thinking like that. So what I'd like to say is that today we don't use the word evidence-based medicine because it's not very accurate. Very often there's no evidence, or that there is evidence, you can't trust that evidence. Or even if it says it's good and you can trust it, you may not be able to afford it. It may not be available. So the best you can do is use the word evidence-informed healthcare. So that is a two-step process. So the first step is to get the right evidence. And then you make the decision, should I use it? So for the first step, we use the methods of evidence synthesis. And for the second step, you have to have a structured way in which you evaluate the evidence to see whether we should use it and put it into our guidelines. Okay, so evidence synthesis refers to the process of finding and combining the results of multiple studies addressing the same question. How do you put them all together? And what you're trying to do is generate new knowledge from what is already done to see, can we believe that what we are doing is correct? Or should we be doing something else? Right? Or if there's something new, how much can we trust that this is actually going to help? So that's what evidence synthesis aims to do. And the methods, the tools are systematic reviews and meta-analysis. Okay, and you can have quantitative methods of synthesizing data as well as qualitative methods, which can complement each other. Okay. So I'll give you an example, because unless I can prove to you that evidence synthesis works in the real world, you're wasting our time. Right. So many years ago, I think in the mid-90s, I just come back from Oxford where I got involved with the Cochrane collaboration. And I started working as a junior consultant in CMC when a friend of mine whom I know many, many years ago rang me up saying that she had already lost one child due to respiratory distress syndrome because it was born premature. And she's now pregnant again. And her pediatrician, her obstetrician says there's a high risk that you may have a premature child again. And he advised her to use a short course of corticosteroids. Because at that time, there was a belief that steroids hasten lung maturity and prevent RDS. But at that time, she wasn't very sure because nobody else seemed to have heard about it. And she was a journalist and didn't trust steroids. So she rang me up to find out if I can find out for her whether this would be. Now, I'm not a neonatologist. So I went to various my obstetrics professors and all, and I discovered why they're all called experts. Each one has a different opinion. Some said yes, some said no, some said I don't know. So then I said, okay, I'll find out for myself. So how will I find out for myself? Two ways. The most common way that people find out is ask a drug rep. That's the continuing medical education that most doctors get in public. So when the drug reps came, I asked them, can you tell me about steroids and RDS and stuff? They all shook their heads. I never saw them again. How else? I went to PubMed. Now, before you go to search, we need to phrase this problem in a way we can actually find the answers. Otherwise, you just put some random terms, you'll get 1 million results in 0.1 seconds, and you won't get through the first 2 pages. So you got to focus what you want to do. So how will you reframe my problem? This is my problem. How will we reframe it in a way that can help us find relevant answers? This is what I mean by saying the first step is defining a focused clinical problem. So I can rephrase it as, in mothers at high risk of premature delivery, will a short course of corticosteroids compared to no steroids, everything has to be compared, prevent or reduce neonatal deaths? Okay, so what I've done here is I've defined the population, I've defined the intervention, I've defined the comparison, I've defined the outcome or outcomes that I'm interested in, and I can also define the time point. When do I want to measure these outcomes? So here it's the neonatal period, right? In addition to that, I have to also say what study design will best answer this question. So this is the focused clinical question, PICOT, PICOTS. Population, intervention, comparison, outcome, time point, and study design, right? So I learned subsequently that there are various kinds of study designs which are appropriate for a kind of question you're answering, right? So if you have an etiology question, or a diagnosis question, a prognosis question, or a treatment question, there are certain primary designs which have the least likelihood of being biased. So if you look down, case series, that means your experience is good. For the person who got better with whatever you gave them, he's happy. But if you want to use that as a generalizable thing, then you need to be more sure that you're not biased. Right? So as you go up the hierarchy in terms of least bias, you'll find that for every question, there is an appropriate primary study design. And for intervention, there is a randomized control trial, if practical and ethical to do. Okay, so I searched for RCTs and I found this study by Liggins. In New Zealand, in Auckland today, there's a Liggins Institute named after this Liggins, because this is a historic trial. The controlled trial of antepartum glucocorticoid treatment for prevention of the RDS in premature infants, published in Pediatrics 72. So I have to now read this and see what the results are and see whether it'll help answer our question. So let's go through this study. This was an RCT done in mothers due to deliver preterm, where they compared steroids versus no steroids. They were randomized, and the outcome, one of the outcomes was neonatal death. And this is the results. So when they had 532 mothers who were randomized to steroids, 36 neonates died and 496 did not die. When he had 538 mothers randomized not to get steroids, 60 neonates died and 478 did not die. There seems to be a difference. But is this difference important? So that's our job, right? So traditionally, you would use the null hypothesis. You'd say there is no difference between steroids and no steroids. And if I want to show there's a difference, I have to make sure that this difference is not due to chance, right? So it's a test for the difference in proportions, who had the outcome or did not have the outcome. And the test you normally use is the chi-squared test, right? And the way you know that it is or is not due to chance is based on your p-value, the test of statistical significance, which is the probability of the difference being due to chance or being not due to chance. And conventionally, we say a p-value of less than 0.05 is statistically significant. Okay, now you can also use the same kind of principle if you're comparing means and standard deviations in two groups or multiple groups where you use ANOVA or t-test. You'll end up with a p-value. And the p-value tells you only that. So what actually does the p-value denote? So it basically tells you how certain are you that the observed difference in the outcomes is due to chance or not due to chance. If you get a p-value of 1, it means you're 100% sure it's due to chance. If you get a p-value of 0, you're 100% sure it's not due to chance. So when you get a p-value of 0.5, 0.5, 50%. You don't know, right? If you get a p-value of 0.1, you're 90% sure this difference is not due to chance, right? So when you get a p-value of 0.05, it means you're 95% sure this difference is not due to chance, right? Keep that in mind and look at this. I've got rows and columns, right? The first and the fourth columns are telling you about the number in a treatment arm and in the control arm, right? So if you look at the columns, there's 5, 10, 15, 20, and 100 in each arm, treatment and control arm. And the next two columns are talking about the response to the treatment or control, right? Now, which is better, treatment or control? So let's go through it. When you had 5 people in the treatment arm, 4 responded. 4 out of 5 is 80%. When you had 5 in the control arm, 2 responded, 40%. And whether you increase sample size or not, that is the response rate. Okay, so according to this, which is better? Treatment. How much better? Double. Okay, but if you look at the p-values, when you had only 5 in each arm, your p-value is 0.29. That means you're about 671% sure that this difference is not due to chance. When you increase it to 15 in each arm, very often PG thesis is 15, 15, 30. But keep in mind, a 50% difference between the treatment and control, with 30 patients, you are now 97% sure that treatment is better than control. And when you increase it to 100 in each arm, you get a p-value of less than 0.0001, which you will interpret as highly significant. And people will read as highly important. Actually, it doesn't mean that at all. Because this difference was there even with 5 in each arm, but you could not demonstrate it because your sample size was too small. That's called a type 2 error. There is a real difference, but your sample size is too small to actually achieve statistical significance. So what this p-value of less than 0.0001 means is you're more than 99.9999% sure that this difference is not due to chance. That's all it means, not how good it is. Okay, so the example I can give you is looking at remission rates for major depressive disorder at 6 weeks, comparing drug A and drug B. With drug A and drug B, it's 30.5% versus 31.5%. 1% difference between the two, but your p-value can be less than 0.0001 depending on your sample size. So this is an example of a statistically significant but clinically possibly unimportant difference. Why? Because it comes from a trial where you control everything. In the real world, you control nothing. You're not going to get the same results. And if you start out with a 1% difference, you can't believe this is going to be helpful. Okay. So the take-home message here is any observed difference between two groups, no matter how small, can be made statistically significant at any level of significance by taking a large sample size. P-values do not tell you how effective an intervention is and whether it's clinically important. It only tells you whether the difference is or is not due to chance and how sure you're about that. Right? So keep this in mind. We are interested in clinically important outcomes. Okay, so what's the alternative? So we have to study what are the effects of treatment rather than test a hypothesis. What are the actual effects? Which is where you come to the usual thing called a relative risk. Right? And the best way I can explain a relative risk is to understand what risk means here. So what is the risk of death in people from the neonates whose mothers were given steroids? Common sense. How many people were given steroids? 532. How many neonates died? 36. So the risk of death with steroids is 36 out of 532. And the risk of death without steroids is 60 out of 538. And your risk ratio is one risk divided by the other. Here it is 0.61. I'll tell you what it means. So risk ratio means the risk of the event of interest in the treatment group divided by the risk of the event in the control group. That is a proportion of people who had that event. Now, the interpretation is, it tells you which is better. When you have an RR of 1, it means there's no difference. Now, when you phrase the outcome in an undesirable manner, negative, like death, relapse, not improved, anything less than 1 favors the intervention. So if you get 0.42, it means steroids are better. And if it's 1.42, it means steroids are harmful, if it's an outcome like death, right? But if you phrase it the other way around, alive or improve, then you reverse the interpretation. Anything less than 1 favors the control, Anything more than 1 favors the intervention. That's the convention. Okay. Not only that, it tells you how much better. So an RR of 0.42 means the intervention reduces the risk of death by 58%. 1 minus the RR. Okay, 58% reduction in the risk of death. You can quantify the improvement. And if you have 1.42, it means how much it increases the risk of death. 42. One, how much more than 1 and how much 1 minus. That's the convention. The other important thing to keep in mind is that we've only got one experiment. If you repeat it many times, you're not going to get the same relative risk. You'll get a range of values. So the confidence interval is a measure of uncertainty. It tells you what is the range of values that you can expect if this was done. And your RR usually will be within that range. It's a measure of uncertainty. It tells you one trial doesn't answer the question for the general population. It's also a measure of precision. The narrower the confidence interval, the greater confidence you have that this captures in, because you need a large sample size to get a narrow confidence interval. And if that narrow confidence interval does not include 1, then you know it helps or harms. So if the confidence interval includes 1, that is 0.5 to 1.25, 50% chance of reduction, 25% chance of increase. So clinically, you can't make a decision on this. And automatically, this is also statistically not significant. Your p-value will be more than 0.05. If it is, say, 0.5 to 0.9, right? It doesn't include 1. That means it definitely helps, right? If it is 1.26 to 1.88, it doesn't include 1. It definitely harms. And in both these situations, if it doesn't include 1, it means that your results are statistically significant. Right? And if you're using mean difference, it is not 1, it is 0. Okay. Now, other important thing is you can try and get an estimate of how clinically important this can be by seeing how far away from 1 is the lower limit of the confidence interval. So if you've got 0.45 to 0.73 is your range, best estimate is 0.45, least estimate is 0.73, you are saying at least 27% reduction. That's pretty good, right? Whereas if it is 0.45 to 0.99, you're saying it could be 1% reduction. That you're not so sure about. So this is one way of trying to see how clinically important it might be in terms of seeing how close to no effect is the least estimate. Okay. Right. There's a term called the odds ratio. Now, the odds ratio is not the same as the risk ratio. The odds of death on steroids is what? So here is the odds of living versus the odds of dying. So the odds here is 36 by 496, not 36 by 532. That's the risk. The odds is dead or alive. So the odds ratio is the ratio of the people who are dead or alive in both arms. And here it's 0.58. That was 0.61 at the same numbers. Slight difference. Now the point is, the odds are favored by mathematicians and statisticians because it is a very robust number, because whether you are dead or alive, it is reciprocal. Look at the odds of dying. It is 36 by 496. The odds of being alive is 496 by 36. You're just switching it around, right? Whereas risk is different. Risk of death is 36 by 532. Risk of being alive is 496 by 530. Totally different. So you cannot take a risk ratio for being alive and intersperse it and say that's the death. It's new calculation altogether. Okay. Odds ratios can be used for RCTs, cohort studies, and case control study, but you cannot use a relative risk for case control studies. You have to have a whole population, and from that you see how many people have. So we usually a prospective design. Case control studies are taken from different populations. So you can only do odds ratios with them. You can't do a relative risk. Okay. The other thing is, with very rare outcomes, if very few people died, the OR and RR will be fairly similar. When you have very common outcomes, they can be very different. And if you have a very high proportion of people having the event, like more than 20% of the people had that outcome, then the odds ratio tends to overestimate the effect compared to the risk ratio. And you should always use risk ratios in RCTs when you have a very common event. Okay, so I'll give you an example. In an RCT, 200 children are randomized to drug A or drug B. If you have a rare outcome there, only 4 out of 100 died with A and 6 out of 100 died with B, your risk ratio is 0.67. And your odds ratio is 0.65. And the confidence interval is virtually overlap. Not very different. But if you have very common outcome, like 40 out of 100 died versus 60 out of 100 died, you'll find your odds relative risk is 0.67, 33% reduction. With an odds ratio, it's 0.44, much greater effect, right? So you have to be careful that you don't use odds ratios with very common outcomes, or you also have to do a risk ratio calculation and see, does it change your overall? Clinicians don't understand what odds ratios are. They will often interpret it as a risk ratio because we think intuitively in terms of how many patients we did, how many got better. Right? So relative risks are a much better way of trying to understand results. If you find a paper is report, an RCT is reported odds ratios, you can convert it to a relative risk. There are simple formulae to do that. Now I'm coming back to help my friend. Evidence-informed healthcare is about people. So can we help her by finding out what is the relative risk with this? Please, I need your help. You can use calculators, telephone, phone a friend, doesn't matter. So what you're basically trying to do is 36 by 532 divided by 60 by 538. It's 0.61. Round it off. That's your relative risk. Now from this, I'd like you to calculate what is the absolute difference, absolute risk difference or risk difference. Basically the difference in risks. So what you do is one risk minus the other risk. 36 by 532. What is that answer? Minus 60 by 538. So one risk minus the other risk is your risk difference. It's here, it is 0.044. And from this, you can calculate what is your number needed to treat to benefit, which is the inverse of the risk difference. Right? So if a paper is only given you p-values, but you have this table, you can calculate the risk ratio, the risk difference, and the number needed to treat. Okay, that's what you should do to actually interpret what happens. But we also need the 95% confidence intervals for these estimates. And there is a formula to calculate it, which involves the standard error and the standard, all very complicated. Just go and download a software. This one is a programmable Excel sheet called the CICalculator.xls. You can download it for free. And you can use it at the bottom. It gives you instruction. One page for instructions. The other one, it says you can calculate the confidence interval for a single mean, or you can calculate the confidence interval for a difference between two means. Or if you've done a prevalence estimate, it'll give you a calculation for what is the confidence interval for the prevalence estimate. Here we are interested in comparing two proportions or odds. So that what you have to do is just now enter the numbers. 16 neonates out of 538 and 36 out of 532 and click 95 instead of 99% confidence interval, and it gives you everything. Right? All you then have to do is interpret these results. Because when my friend calls, I have to tell her what exactly these mean. I can't tell her absolute risk reduction. I have to use language she can understand. So what does this evidence tell us? The risk ratio 0.61, 0.41 to 0.90. How do we interpret this? Translate these numbers into any language, English, Marathi, whatever language you're comfortable with, so that you can communicate. Tells you that this COCHRANE study, which involved about 1,000 women at risk of premature delivery, When they took a short course of steroids compared to not taking steroids, the risk of a premature neonate dying was reduced by 39% compared to she didn't take steroids. The worst case is 10%. That is 9.90. And the best case is 59% relative risk reduction. That's one way of telling her that. Or I could tell her the risk difference. This tells you treatment with steroids would prevent 4 less neonatal deaths per 100 births. That is 0.044 divided by 100 and round it off. Than treatment without steroids. It could be 1 to 8 less deaths. But it's all less, right? 1 is 0.10 divided by 100, rounded off. Same with 0.79. Okay. Or I could say that one would need to treat 23 mothers with steroids to prevent 1 neonatal death compared to not using steroids. It could be as few as 12 mothers, or it could be as many as 104 mothers. Which would you prefer? If my friend was to call you, which would you use to tell her what she should do? You tell all three, she'll get confused. Risk. There's a systematic review which shows that clinicians and patients like risk ratios. But if you're a manager or someone who's forking out the money, you prefer absolute. How much absolute difference is it going to give before I invest in it? So if it's a very cheap invest, thing, it doesn't matter so much. Anything which is a single digit is fantastic. Even 20 up to 20, depending on how cheap it is and how difficult it is to use, that's the kind of decision making you can make from these things. Okay. What if the relative risk of death was 0.78, confidence interval 0.66 to 1.22? Answer is, I don't know. Because the risk of death is reduced by 22%, but it could be better, 36, or worse, 22 increase. That means we don't know what the effect of the intervention is on death, right? Is it statistically significant? No, because it includes 1. So p-value will be more than 0.05. What is the relative risk of 1.26, 1.06 to 1.39? Risk of death is increased by 26%. It would be 6% to 39% increase. Death is definitely increased. Is this statistically significant? Yes. It does not include 1. You may not like the answer, but it is statistic. It's not due to chance. Okay. So now we have to move from evidence to practice. Right? So should I tell my friends to use steroids? So how do you answer that question? The risk ratio is 0.161, right? Should I use this and tell her, please use steroids? It is statistically significant and clinically important. So what? Yes or no? How do you know you can trust the evidence? It will be pure rubbish. The numbers seem to convince you, but you need to look at the methods, right? That's called internal validity. How true are these results? Only then can you say, I want to use the evidence. That is external validity. Can I generalize this to you? So at this point, we've only got the first bit. We know this is likely to be a useful intervention. Now we have to find out, can we trust it? For that, this will help you interpreting the evidence, because internal validity is true wherever in the world you read the article. That's the actual results. External validity depends on where you are and the circumstances you're under and where you want to use it. Okay, so this will help you. What does this tell you? You're searching for the truth, no? What is the truth here? Okay, just imagine you've seen this. It's emblazoned in your brain. Now, just imagine you were coming from the traffic light towards them, not having seen this. What would you have thought? You probably would have thought what the guy in the center is thinking. He's writing a book about it. It says 7 habits of highly successful and popular people who are also very sensitive boyfriends. Now there's a problem here, no? We know. The people on the other side won't know, right? Problem is, this guy represents bias. And what I mean by bias here is, he's got a preformed idea about what a hotshot is, and the method he is using to verify that is where the problem comes. She's coming out with me, he's coming out with me, so I'm popular and sensitive. That's his thing. It's going to be a costly mistake for him because it's quite possible what she's thinking is he doesn't care for me. He's such a conceited idiot. All he thinks about is himself. His friend is a very sensitive guy. He's a good listener. I like talking to him. So that is probably the reason why he's going out. And this friend is actually what you call a confounder. A confounder is an independent variable which influences the outcome. So she's going out with him because through him, she has a non-controversial way of finding someone to talk to. So confounders are very tricky because sometimes confounders, usually it's found that when you have a confounder and you're not balanced for it in a trial, you get overestimates of benefit. But sometimes it can be the other way around. What if, for example, this guy is thinking, I don't know what these guys are going to say when they find out I'm gay. So you didn't expect that. So there are known confounders and unknown confounders that will be able to handle both. This is the other example you must think about. What is this? Surfers in some place near Australia. Every day they're looking for this perfect surfing wave. On this particular day, they found another bunch of surfers, a whole school of dolphins. When I saw this, I said, how in the world did they get this picture? Were they in the right place at the right time as coincidence, or does it occur every day, or is it a photoshopped image? So these are the problems we will undergo when we are trying to evaluate any publication and see, can I believe it? Right? So threats to internal validity, anything that deviates the results from the truth. Usually it's due to systematic errors in the methods called bias or random errors due to chance. Bias includes confounders, right? Now we know how to understand chance because you increase sample size, look at your p-value, look at your confidence interval, you know whether it's due to chance. But you cannot detect bias by looking at p-values. You need to know the methods of the study which should be in place to reduce the risk of bias. Now you may have heard about these things this morning in RCTs. Now tell me, why are we randomizing? There are two critical aspects for randomization. One is the process of randomization, right? Why do we randomize? Sorry? We want to balance confounders, right? So any normally distributed variable, like age, sex, all of that, in that population you're from, will fall on both sides if you randomize properly. If you go to a population which does not have all the variables in the normal distribution, then you have to stratify and randomize. Okay. But the other thing about randomization is not just balancing thing, it has to be unpredictable. That means the people who are going to recruit should not know who's getting. For that, you have to have a way of concealing the allocation by either a central randomization process or a serially numbered, sealed, opaque envelopes. Some method should be there. So you have to read the paper to say, how did they randomize? If they, for example, said every third white patient I enrolled, what is the problem with that? Everybody knows. Third white patient this time, you know to count who. So if I know who the next person is likely to be, I may be biased and change the randomizing. I don't want this guy to come in here because he's my friend. And I think he might get the wrong treatment. What's the problem with that? You will unbalance confounders because you do not know what the known and unknown confounders are. So the person recruiting should not have access to the randomization code. That's called allocation concealment. That is a crucial part of randomization. Okay, blinding or masking. Ophthalmologists don't like the word blinding. Masking participants from the intervention serves two purposes. One, it prevents performance bias. You do not know what they're taking, so you can't say, oh, he might have a side effect, I'll give him an extra pill. So you're making sure everybody gets the same treatment because you don't know what they're taking, right? And the other thing is that you should worry about the people who entered the trial should be accounted for in the numerator and denominator at the end, right? And you should make sure that if you're not using subjective outcomes, if you've got objective outcomes like death, it doesn't matter who's recording the death. But if you've got a subjective outcome like some score on some scale where you have to help the patient get the result, then you should not know what they are on. And ideally, they should not know what they're on, right? So the outcome assessor should be blinded. And all the outcomes should be reported in the way they were intended to be in the protocol. So these are the domains that you have to be able to read the paper and figure out, have they reported it? If they reported it, you think they did it, and did they do it properly? Then you come to a judgment about, is there a risk of bias in this particular domain? Fortunately, because if you don't, you'll find that there is a lot of research which shows these are all areas where your results can be wrong. That's why we are assessing these domains. Okay, so fortunately for me, this paper was well reported and free of the risk of bias. So now my friend is going to call, and I have these two aspects sorted out. Useful results, a lot of validity. Now what? Can I use it? Should I ask her to use it? So we've got these three bits. It's useful, outcome is important for the woman, and I can trust the results. Shall I give it? Some people will say this is done in Auckland. How do you know it will work here? You have to ask yourself, is there any biological reason to believe it will not work here? I couldn't think of any. But there is one issue, safety. The paper didn't describe any adverse events. And I thought, what is the adverse event? You can get some gastritis. Well, but there's also a risk of sepsis. And there's increasing evidence now that when you roll out these steroids in developing countries where sepsis is not really looked after, children can get more infections. So I have to tell her there is one risk, but she's a person who's a precious baby who actually called me to find out should I use steroids. She clearly will be careful, but she needs to be warned that you have to maintain sepsis, clean asepsis. Is it affordable? Cheap. Is it available? Over the counter without a prescription. Is it practical to take? Very simple. You don't have to admit and give IV fluids or an enema or anything. Are there any other alternatives? At that time, couldn't think of any. Any other question? What do you think you should do? What is your preference? But I can only help her to elicit her preference after I've given her the information which can advise her, give her information to make an informed decision. Now, can I ask her to take? How do you know you have all the evidence? I have only one trial, and the world is not fair. You'll find very often different trials. So here I am showing you the results of the ligands trial in a graphical form. The vertical line is a line of no difference. To the left of the line is less than 1. That blob is the risk ratio, 0.61. The width of the confidence interval is from 0.41 to 0.90. One look at it and you know this helps. I found another trial, same PICO, smaller sample size, wider confidence intervals, which do not rule out the possibility that the child could be worse for people given steroids. So this is when I came across the logo of the Cochrane collaboration, which is one of their first important systematic reviews, meta-analysis. They had 7 trials because they were systematic in their search of steroids versus no steroids to prevent death. And 2 trials, apart from ligands, there was one more which favored steroids. And 5 trials, not sure, may even harm. So now we've got 2 trials versus 5 trials. Which would you give or don't give? 2 trials saying it works, 5 trials saying it doesn't work. Give or don't give? Assuming that they're all there. Just telling you, result. Yeah, so the point here is I'm asking you to do vote counting. Now, the problem with vote counting is 2 trials, they are large trials, right? And they've got definitive results. The 5 trials are smaller trials, wider results. If I do vote counting, I'm giving them all the same weight. They cancel each other out, which is why you need to combine them in a meta-analysis where more weight is given to the results of the studies with more information. That's what a meta-analysis does. So based on that, clearly shows that steroids help reduce risk of death in neonates. Now I went back and looked at an update. There are even more updates, but this is a 2010 update. Because in 1995, I had seen that. No? And the results by then had 21 studies, Some women had twins. And treatment with antenatal corticosteroid did not increase the risk of death to the mother, did not cause any sepsis, at least from studies done in the developed world. Right? And with more confidence, you could say that it reduced neonatal death because now the lowest confidence interval is 0.81, not 0.9. Right? That was the original result. But since digging into the large study, it has clearly influenced the overall result. What it also told me was lots of other outcomes. Where because different studies have different outcomes. And if you're interested in them, you can pool those outcomes also. I want you to look at all these results and tell me, are these results statistically significant as likely to be clinically important? Simple. What is the outcome? RDS, undesirable. Less than 1, more than 1, less than 1. That means steroids are better. How much better? 1 minus 66, 34, 34% reduction. What is your least estimate? 27% reduction. I'm happy. Okay, go down. Cerebroventricular hemorrhage. What is the least estimate? 0.69. Pretty good. Necrotizing enterocolitis, least estimate 0.74. Happy. Respiratory support, intensive care admissions. The relative risk is 20% reduction. The least estimate is 1% reduction. Why? Came from 2 small studies. Is that statistically significant? Yes. It doesn't include 1. Clinically important? I don't know. I'm not really sure about that. Okay, and systemic infections in the first 48 hours of life, estimate is 0.56, which is pretty good. The least estimate is 0.85. Now, if you think a 15% reduction is important for you, good for you. It's up to you. Where do you set your minimum important difference? That's what we're looking at. Okay, go on. Half an hour more. We started a little late. Okay, so what we are now, I've demonstrated to you as a kind of a basic building block for you to understand what systematic reviews are, that we need to be able to summarize from a systematic review enough information that a policymaker or somebody who's making a decision can grade in a structured manner, transparent, so you know why they did it like that and why are they recommending this. That's what this whole exercise is about. So for this systematic review, we need to understand what they actually are. So how does it differ from a traditional way of reviewing literature? Basically, you have a methods section where in advance you lay down very clearly what are you looking for, where are you going to look for it, what search terms are you going to use, who all are going to find it, who's going to do what, how are you going to decide which ones to include and exclude. When you include, are you going to tell us which are the studies you excluded and why did you exclude them? Right? And when you include the studies, tell me more about the studies. What were the methods? What are the participants? What are the outcomes? What are the results? And what are your thoughts on the way the study was done in terms of the risk of bias? And then when you pool the results, what are the methods you're going to pool the results? Are you going to use risk ratios or odds ratios or mean difference? What is you going to use? And when you pool the results, what are the methods you're going to use to do a meta-analysis and to interpret whether the results are all homogeneous or heterogeneous? And if there is some heterogeneity, how are you going to deal with it? All of this is designed in the protocol of a systematic review. Traditional review articles don't have protocols. They don't have a method section. That's the main difference. Okay. So we want to start with a clear objective and the methodology, which is transparent, so somebody else can do the same thing and get the same results. And we want to be able to find all the studies, not some of the easily obtained studies which have positive results. That's why you can find them. They got published because they're positive results. So if you pull together the results of positive studies, you'll get fooled into thinking it works. Unless you add the negative studies, you won't get a balanced result. Right? So your strategy should be wide enough to get all that. And you should be able to trust the studies themselves as well as the pooled estimates from those studies for their outcome. I'm giving you a risk of bias for the study. But then when I pool all the results together, I'm taking them outcome by outcome. For the outcome of death from 5 studies, which are the studies which were biased? And if they were biased, how biased were they and how much are they contributing to the overall meta-analysis? Then only I can say, can I trust these results? So that's all methodology of doing a systematic review. and you have to present all these in a way that people can understand it. The meta-analysis is actually an optional part of a systematic review. It only describes the statistical technique used to summarize the results. So you're trying to say, on average, for the outcome of death, compared to drug A, how does drug B do? What's the average result from these trials? A weighted average, right? And the advantage is because you're increasing your sample size, you get more power and therefore more precision in your results. That's the idea of trying to combine. But if you don't do it outside a systematic search for all the evidence, you may get publication bias where you only find positive studies, right? And if you do not assess the risk of bias in the studies, you'll get a result, but you do not know whether you can trust that result. And if you don't look and see, are the results consistent? And if they're not consistent, why are they different? You will get an unreliable result. And then you need to be able to see from the population outcomes and all in the studies, are they similar to what I want? Or have they excluded this kind of populations and treatments that I'm interested in? That's what a meta-analysis is about. Okay. So if you actually use it properly, you can save huge amount of lives. Now, if you look to the left of the line, what you see is a forest of lines. This is called a forest plot. Each line represents an odds ratio and 95% confidence interval of 33 trials done on 36,000 odd patients over 30 years. They're comparing IV streptokinase versus no streptokinase to prevent death after myocardial infarction, right? 6 trials clearly showed benefit. The rest of them are too small, wide confidence intervals, right? But when you did a meta-analysis, a pooled estimate, it shows that treatment, steroids, streptokinase saves lives. So the author of this paper asked, did we need 33 trials, 36,000 patients, and 30 years to answer this question? Or could we have known this earlier? So on the right, he did a cumulative meta-analysis where every year a trial came out, it was added to the previous year's trials, cumulatively to see where we stand. By 1973, after studying only 2,432 patients, you had evidence that streptokinase saves lives. But the world continued to randomize 11,712 patients in 1986 and 17,000 patients in 88. Right? If you were in an ethics committee in 1973 and you had been given this pool result, it's highly unlikely you would have approved the other studies because that would have been unethical. Right? All you ended up with more narrow confidence intervals because your sample size became huge. While that was happening in the world of research, you look at what experts were recommending during that time. So the right side, you will show textbook recommendations and all that stuff. No? There was clear evidence of benefit from 1973, but the recommendations only changed in the mid-80s. And there was severe criticism, including the Oxford textbook of medicine, David Vellore. He publicly apologized, saying, sorry, we didn't know these methods. The world changed because of these kind of reviews. Instead, what were people recommending? Prophylactic lidocaine. Continuing to show no evidence of benefit cumulatively, recommended way into the 1990s. Right? So the editorial said advice on life-saving therapies were delayed for more than a decade, while treatments which were recommended long after controlled research showed them to be harmful. So that's why we have this pyramid where we consider systematic reviews and meta-analysis to provide cumulative evidence, and if done well, they can change lives. But this is a misleading figure because it seems to believe there are only randomized controlled trials and interventions. That's not true. As you've seen, every design has an appropriate primary study. And a systematic review of those studies will answer the questions for those etiologies. It could be a systematic review of cohort studies, not just RCTs. Okay, so now we move very quickly into what the systematic reviews are. So basically a systematic review, you're formulating a question, getting a team together, planning your title, you write a protocol, and you either publish the protocol or you register it in an international website called Prospero, where you get a Prospero registration number like a trials registration, right? Then you devise your search strategies, you locate the studies, and then you assess the studies for risk of bias, and the studies you exclude, you give us the references and why you excluded them. Then you extract the data from the studies according to your plan and enter it into software, and that software will analyze and give you the results in the form of a forest plot. And then you summarize the results and get a summary of findings using a particular approach called GRADE, which I'll briefly touch upon. And that should guide your review. This is the steps of doing a systematic review. Okay. So the protocol tells you this is what I plan to do for the results onward. So it's like you're walking through the whole thing in advance and writing it down. Okay. Now, I'll give you an example of a systematic review. I'll probably rush through it a little bit because we are running short of time. But some time ago, a girl called Gauri Galapati, who was working in Sri Lanka in the Ministry of Health anti-malaria campaign, she asked this question: why is it that India, Sri Lanka, and Pakistan and countries like that, when they're treating Vivax malaria, are using 5 days of primaquine following chloroquine, when WHO recommends giving 14 days of primaquine to eradicate the hypnocytes, which go into the liver, after you kill the blood form with 3 days of chloroquine? WHO says give 14 days. India and all are giving 5 days. So she took this question to Paul Garner, who was the coordinating editor of the Cochrane Infectious Diseases Group when she went there for something or the other. And he got in touch with a lot of people. We were working with Paul Garner at that time. So he asked us to help them to do this review. So we did this review and we got it published. And if you want to read it, you can go to the Cochrane Library, cochranelibrary.com. And in the search, you write primaquine, Boolean A and D, Vivax. And you'll find there are 7 Cochrane reviews with this. There are 258 trials. Look at the top index. It says 258 trials on this. Okay, so if you look at the trials, the one we want is this one. Reviews. Systematic review. Primaquine for preventing relapse in people with Plasmodium vivax malaria treated with chloroquine. Okay, and if you click on that, you'll get the HTML version and also a PDF. You can download this PDF because this review is free, open access, right? And if you can read it on the PDF or you can read it in the version. So what a review here will start with the background. There are 4 parts to a background. What is the condition? So we describe how serious Vivax malaria now is. It used to be considered a mild form, but it can cause severe disease as well. And it can also cause relapses. Usually occurs within the first 6 months. Reinfections are common, especially in younger people, right? And what are the interventions? Standard intervention is give chloroquine over 3 days, a particular body weight, and then followed by primaquine for 14 days. That's a recommended treatment. Total dose is 210. But primaquine can cause hemolysis in people with G6PD deficiency. And testing for G6PD deficiency is a little expensive. It's not commonly available. Less commonly, it can also cause methemoglobinemia, although it's usually very mild. Now, ACT combinations are used in falciparum malaria, but they don't work against hypnocytes, right? And there are other drugs which are not yet in common use. So the intervention is chloroquine, primaquine, 14 days. Now, how does it work? Chloroquine kills the infective parasite rapidly within 24 hours. That effect lasts for about a month, right? And if you find a parasite within that month, it means chloroquine has not worked. So chloroquine resistance, right? So any parasite detected after that period within the first month is usually considered a relapse. And after that, it could be a relapse or a reinfection. And now we know we can't use PCR to say whether it's a relapse or reinfection like we can do with falciparum. So it's just a question of time. How soon after treatment did the relapse occur? So it's important to do this review because this actually was an update. We had already done this earlier and it kind of changed our policy to some extent. But there are many other questions. Many people don't take the tablet because, after 24 hours, fever is gone. That's one issue. Second is some people are worried about G6PD deficiency. Then the third is that very often because the G6PD tests are not done, for example, the Pashtuns in Pakistan have G6PD deficiency. So they don't give them primaquine at all. And then also in some parts of the world, there is primaquine resistance. So there have been a lot of different alternatives people are suggesting. Use a higher dose of primaquine for shorter periods so that people are more adherent. Use higher doses after 14 days to overcome resistance. Make sure that the total dose is 210. Or what about higher dose, total doses? And don't give it sequentially, give it concurrently. So this is the state of the evidence. And even more than that, people in India were saying there are places where relapse is not high. Don't give primaquine at all. So if we want to make sense of all of this, we have to address all these questions. That's our background. So our objectives were, one, compare WHO regimen versus any other regimen of giving primaquine following chloroquine. Okay. The second was, what if you don't give primaquine at all? So these are the two objectives of our review. Okay. Then we have to make sure the PICO, we have to make sure we get the PICO because that will help search better. So type of studies, randomized controlled trials or quasi-randomized trials. What are quasi-randomized trials? Where you can anticipate who's going to get what every third day, that kind of stuff, where you cannot conceal allocation. We said we will take them there in because a lot of papers don't describe how they're randomized. So if we include them, then by excluding somebody who tells you how you randomize, you're biasing yourself. We will then assess each of the studies based on the risk of bias, but we will include them in the review. Okay. Participants were adults who have pure Vivax malaria and children. Okay. And the interventions were for the first WHO regimen versus any other way of giving primaquine following chloroquine. And for the second thing, it was primaquine plus chloroquine versus placebo or no intervention after chloroquine. And the dose of chloroquine should be same in both arms. That is our intervention. Outcomes, we really were looking at Vivax parasitemia after 30 days, which denotes that it's not chloroquine resistant, but it's primaquine resistance and severe adverse events. Then we also looked at any other adverse events specifically known to occur with primaquine or others. That is only what things that we felt were relevant from a public health point of view. And then we had our search strategy. So Cochrane searches multiple databases because often the overlap is not very much. Embase is a European database. PubMed is Index Medicals, which is the North American database. So you may find trials in one, you won't find in the other. So you got to search for that. Search, ask for experts. We hand search many journals which are not indexed. And then we looked at the citations and we looked at ongoing trials and the trials registers and then conference proceedings. So all of this is detailed, advanced, what all we search, what dates, everything. And what are the search terms that we used in all of these. And then which are the conference proceedings that we looked at. It's all there in our appendices. And then what are the other resources that we searched? Fortunately, Cochrane helps you because they've got trial search coordinators help you do many of this. Then we wrote, how do we select the studies independently? We have to extract and look at risk management. And then we have to assess the risk of bias. And and also say, how are we going to summarize the results and what are our main outcomes for the summary of findings table, right? And then you come to the results section where initially you qualitatively describe what you found. How many trials, which countries, what are the age groups, and which are the studies you excluded, like a flow diagram, like a consort diagram, right? So we finally ended up with 15 studies for meta-analysis in this. And each of the studies, we say, what are the interventions that they looked at? Now, if you look at the interventions for the first objective compared to WHO standard, we had 2 trials comparing 3 days of primaquine to standard primaquine treatment. Then 3 trials compared 5 days of primaquine to standard treatment. 1 trial compared 7 days of primaquine to standard treatment. And 1 trial compared 45 milligram given weekly for 8 weeks to 14 days. Now, we are not going to combine all of this in a meta-analysis. Each is an intervention, is a comparison. Only those similar comparisons will be combined. Do you understand? I'm not going to compare a 3-day, 5-day versus 14. That makes no sense. Then if you look at no primaquine, 4 trials examined primaquine given for 5 days versus nothing, and 10 trials evaluated primaquine given for 14 days. Interestingly, many of these trials were from India. Right, it's all local evidence. Then we also see which of the studies we excluded. So a list and why we excluded them, not an RCT, wrong comparison, what are the reasons for exclusion. And then each study we decide the methods, the number of participants, the exclusion, inclusion criteria, and the interventions. This is a 3-arm trial. And what were their outcomes, which we use in the research. They may have other outcomes we didn't use. Okay. And then the risk of bias. We start looking at what are the specifics of this trial, which we are worried about. Now, if it says here, the trial authors base sample size estimation on an assumption that relapses will be 30% in chloroquine and 4% in 14-day primaquine, and allowed for 20% loss of follow-up due to income data. And they aim to get 150 participants with 50 in each arm. But what they reported was they had chloroquine alone 50, chloroquine plus primaquine 5 days 59, and the third arm, which is 14 days, 42. What do you think? Is there a problem here? See, this is the only signal you'll get that there's a problem. They said they're using 1:1:1 randomization to achieve 150 people, which means 50, 50, 50. They said they use allocation concealment and all, the serial envelopes and stuff. But when they reported the results, they've got 50, 59, and 42. Does it ring a bell? An alarm bell? Yeah. It clearly means that the allocation concealment was not done. Somebody, Gujal, the code got mixed up, which is why you got unequal numbers. Because if they did, as they said, there'll be only 50 for each group. You cannot get 59. So something went wrong here. So when we assess the risk of bias, random sequence generation, they had computer-generated randomization schedules, so low risk. Allocation concealment, high risk. So we are explaining that if they completed the whole 150, then there is no way they can have anything but 50-50 in each arm. So something was compromised here. So we are saying high risk of bias. Okay? And the other domains also will give our reasons. With this, the program will generate these figures for you, which tells you across all the studies what proportion had high risk, low risk, and stuff, and a risk of bias summary for each study. Okay. Then you have to decide, should we meta-analyze? And you can do that if you've got more than one study, which has got similar outcomes and all, and where they get the data, where they've given you the data. And when the data are consistent, if you've got very inconsistent studies, it's better not to pool the results. Okay, so you can do a review without a meta-analysis and narratively describe your results. The principles are, we are looking at a weighted average of the effects of one intervention compared to another. You need at least 2 studies with comparable outcomes and populations, and you're not comparing across studies. Each study, you get the relative risk because you don't want to break the power of randomization. You analyze them separately, and for each outcome, you take data from which studies gave you that outcome. For the outcome of relapse, you take data from studies which have described it, and then you enter that, and for each outcome, you have a separate forest plot. Okay? So some studies will not contribute to all the forest plots because you don't have all the outcomes. And then you calculate your summary statistics, which is weighted, right, to give the average. And each study's estimates are differentially weighted. So some studies give more weight to the analysis. So you look at your comparisons, decide on your outcomes, enter the data outcomes, and decide whether you want to use relative risks or what, meta-analyze. Then you look for consistency. If there is inconsistency, you try and explain it, or then you have to deal with it. And finally, you interpret the results. This is a meta-analysis. You'll do more of meta-analysis this afternoon. But I'll just briefly go into what of it. So the kind of data you can get is dichotomous, dead alive, ordinal, mild, moderate, severe, continuous, censured data. All of this, in the afternoon, you go on how to deal with all of that. And the statistics you're using for binary data is risk ratio or odds ratio or risk difference or mean difference or time to event. Okay. Now, how do you weight? The rule is this. If you've got more participants and more in events, especially in the control group, that's called a baseline risk. Meaning, if you have people in the control group who had no event, That means they didn't need the intervention. Right? So that study is uninformative. Whereas if you had a group, the control group had a lot of events, and then the events were reduced in the other group, that is meaningful. Automatically, the variance will come down. Right? And I would like you to remember that weight is proportional to inverse of the variance. So if you've got a wide variance, you get less weight. You've got narrow variance, you get more weight. And since the variance is used to calculate your confidence intervals, you think of it like narrow confidence interval, more weight. Wide confidence interval, less weight. Right? These are 6 studies where people had head injury and they were given controlled hypothermia. And these are the relative risks and confidence intervals from these studies. Which study should get more weight? Which one? 4th one. You have no doubt about it, because it's the one with narrow confidence intervals. Now, these are the actual studies. Which one should get more weight? You're not so quick off the block here.
Yeah.
Huh? 4th, not the 5th. How many think 5th? Those who said 4th are correct, because also depends on the control group risk. The risk in Marion is 10 out of 42, and in Jiang is 14 out of 24. Right? The risk is much higher in the control groups. Anyway, the way, if you look at the weights given to study, Jiang got the most weight, followed by Marion. That's the way. You don't have to worry about it. The program will do it for you. But this is the principle on which weights which is given. And if you look at the formula, it says the weight given to each study is the number of events in the control arm, right, into the total number of people given the treatment divided by the total number randomized in that arm. That's it. Therefore, the control group event rate or the baseline risk, as well as the total sample size, determines what the weight is. Now, if you look at forest plot of corticosteroid versus placebo, if you look on the top here, I have got risk ratio using a fixed effects Mantel-Hansel method of pooling results, right? And it's 0.69, 0.58 to 0.81. That's a relative risk reduction. I can use odds ratios. Here, the odds ratios are slightly different. Okay, because these events are 200 out of 1,988 and stuff. Now, to help you understand the forest plot, how many studies are there? 1, 2, 3, 4, 5. Identified by the surname of the first author and the year of publication. And in these 2 columns, the number of events who died, people who died given drug A and drug B out of the number of people given drug A and drug B. And that's the relative risk for each study. No weights applied. That's the relative risk as it is, right? And that's the graphical description of the relative risk against the line of no difference. The blob is the relative risk, and the size of the blob corresponds to the weight given to that study, right? If it crosses over 1, we don't know. If it's on the other side, it favors drug B. If it's entirely on this side, it favors drug A. Now, the weight given to the study, pi got the most weight. Why? 60% of the weight is for pi. Narrow confidence intervals. The sample size is a misleading. Narrow confidence interval. Which is the study which had the next largest sample size? Jesani. How much weight did Jesani get? The least weight. Why? Widest confidence interval. Confidence so wide. So it's inverse variance, no? That is inverse of the confidence interval width. Pooled effect estimate tells you what? Drug A versus drug B. Drug A reduces the risk of death by 30%. It could be as good as 50%, but it could be as little as 1%. Is it statistically significant? Yes. That's it. P is 0.04. If it goes to 1, it will become P 0.05. Statistically significant, but clinically we don't know. Okay. So that's how you interpret the results of a forest plot. And I won't talk about continuous data because you can do that in the afternoon. I just want to Yeah. The next step is to look and see, is there heterogeneity? So what I mean by heterogeneity is the results of the studies are not consistent with the overall results. And it matters because it then doesn't mean that you're giving you the average effect across all the trials. You're ignoring some studies, right? And it may tell you that some trials the intervention works better, and it's more important for you to know why rather than just hide it. So what we want to know is, does drug A have a fixed effect in all of these studies? That's what is meant by a fixed effect random. You're assuming that drug A compared to drug B works in the same way across all studies. That's called a fixed effect meta-analysis. And that is where you differentially weight so that the studies which have got more information, narrow confidence intervals get more weight, assuming that the drug is working the same way in all the studies. That's the assumption. Now, you can get heterogeneity if your populations are different, if your interventions and comparisons are different in each trial, when your outcomes are measured in different ways or at different time points, or when the methods of the trial are different, or it can be due to chance. So we have to be able to see, is there a heterogeneity detected, assess if it is due to chance, and quantify how much is chance, how much is true difference in the results of the trials. And if there's a lot of heterogeneity, do we combine it? Or do we explore it and try to understand it? Or then if we can't do that, but we still want to combine, how do you incorporate it? That's what we will do here. So looking at our thing here, detecting heterogeneity. Is there heterogeneity? The first is eyeball test. Do the confidence intervals of the trials overlap? Clearly, the third trial is so different from the others. They don't overlap at all, right? So a confidence interval is like a prediction. George, 1919, said, I think the risk ratio will be 0.31, anyway from 0.07 to 1.37. Thomas fell within that, but extended it a little further. Now it could be anywhere from 0.07 to 1.75. Then if you look at Srinivas, fell within that. Pi fell within that. Jesani completely outside that. So that's the first test. How do we know this is not due to chance? There is a chi-square test for heterogeneity. And your p-value tells you you're more than 99.9999% sure this difference is not due to chance. Right? And there's a test called the I-square test, which tells you how much of this exceeds chance. I-square 87 says 87% of the variation in the results is not explained by chance. Only 13% can be explained by chance. Okay, so this is how you interpret a forest plot and look for heterogeneity. First is confidence interval, do they overlap? Second is, does the chi-square test in the p-value say there is heterogeneity? Because there are very few studies, often you may not get a p-value of 0.05. So even a 0.01 they'll say is suggestive of statistical heterogeneity, right? And your I-square tells you how much of this variation exceeds chance. So minus 100 will tell you how much of it is due to chance. So when you got something like this here, you've got to be very careful of the result, because it clearly doesn't represent an average effect across all the studies. So what are the ways we can deal with it? If you got p-values is less than 0.1 and the confidence don't overlap, but your I-square is only 25% or less, that means 75% of this is actually chance. Only 25% exceeds chance. You can assume that the drug is working in a fixed way, and that is just random error. So that's called a fixed effect model, which basically tells you the true effect for each trial is actually the same as the pooled effect. That's the true effect, but you're getting these variations because of random error or chance. That's the assumption of a fixed effect model. Okay. Now, other option is if you get 75% or more, then you can ignore it. Don't ignore it, don't pool. It makes no sense to pool. But if you get somewhere in between, that is when you have to worry. So one option is to try and explain it, okay, in a subgroup analysis. So what I mean here is, we are looking to see what could explain why these studies are different. So here, looking at these studies, if I want to do a subgroup and look at the inclusion-exclusion criteria, and if I find that Jesani was one study which did not eliminate people who had cardiac problems. All the other studies excluded people with cardiac problems. So that's one separate subgroup. What are the results now? In the group with no risk factors, your relative risk, there's no heterogeneity, and the drug really works in preventing death. Whereas with cardiac risk factors, it's going the other way, but we don't know what, it's only one study. So we can clearly tell you that if you have no risk factors, this is the effect of drug A versus drug B. That's how you explain the heterogeneity. And here we are not giving you a pooled overall effect. We're giving you only the effect in the subgroups. The other option is finally unexplained heterogeneity. You can use a random effects model where you say there is not just one source of variation, which is inter-trial difference within the subjects variance. There is also between subjects, there is a lot of variance. So we'll incorporate most of that also. And what we're telling you is we are not giving you a precise pooled estimate. We're giving you a range of effects. And your point estimate is only a mean of that distribution of effects. So there are two sources of variation here. One is random error, and the other is actual difference in the results because something is different in the trials. So when you do that, you will have to account for variation in two ways. So 10 minutes more. This is a fixed effects model, and at the bottom, I've changed it to a random effects model. It doesn't change the heterogeneity, but what it does is it changes the result. What's the difference? The random effects model, you get wider confidence intervals. And why does it occur? The weights given to the study are different. The random effects weights are more equally distributed than the fixed effect weight. Right? So therefore, a study like Jasani, which got no weight in, virtually no weight in the fixed effects, is now getting 20% of the weight. And Pi, which has 60% of the weight in fixed effects, is now getting only 22% of the weight. Why does that occur? Because the formulae are inverse of the variance. With a fixed effect, there's only one source of variance. That is, within each study, people differ. That's the only reason there's variance, right? In a random effects meta-analysis, there are two sources of variance. There's variance within the study, and there are variance between the studies. So when you increase the source of variance in your denominator and your heterogeneity increases, your inter-study variance becomes huge, right? Therefore, the weight given to that study becomes less. That's why random effects meta-analysis, the weights are more evenly distributed than fixed effects meta-analysis. Do you understand what I'm trying to say? Each study, there is some variation in between people, right? But if all the studies, the between people variance is similar, then you use a fixed effects meta-analysis. But if you find that variation, one study is like this, the other one is that way, then you've got two sources of variation. Within the study, there's variation, and between the studies, there's variation. To account for those two, the weights then change. Right. So chloroquine versus primaquine. What does it say? 5 days of primaquine following chloroquine is as good as giving no primaquine. That is our national policy. As good as giving no primaquine. 14 days of primaquine following chloroquine versus chloroquine alone, much better. 14 days is much better. Can you see that? Okay, so these are indirect evidence from across these two that 14 days is better than 5 days. Yeah. Then if you compare directly 5 days primaquine versus 14 days primaquine, and you look at supervised treatment, unsupervised treatment. Remember that study I told you about Kim, who had unequal numbers. The other problem was they didn't supervise treatment, and they couldn't make sure that patients actually took the medicines. And they found no difference between 5 days and 14 days. And they admitted it, that maybe it's because we don't know whether they took their medicines. So we have kept that a separate subgroup, unsupervised treatment. But the supervised treatment, we know clearly that there is a 10 times better result in favoring primaquine and chloroquine. Okay. 3 days versus primaquine, 14 days is better. 7 days versus 14 days, 14 days is better. So every which way you look at it, 14 days of primaquine is better than giving no primaquine or even giving 8 weekly. 8 weekly, we are not really sure, there's only one trial. So when you get all these results, finally we have to summarize the evidence. No? That's the last bit. You're interpreting and giving people a summary saying, for the outcome of relapse and adverse events, how does 14 days compare with anything else or nothing? So what we are trying to do is to provide an evidence footprint. Any policy document should have an evidence footprint that tells you, why are we saying this? Right? Because it's a matter of people adopting it. And when you have very few resources, you need to be sure you're going to spend your money fruitfully. Right? So what you need from a results is, can we trust the evidence? So what is the risk of bias in the individual trials giving you data for that outcome? Is it high or not? If you can't, you think there's a lot of bias there, your confidence in the results comes down. Similarly, how directly is the evidence applied to me? For the outcome of relapse, are the patient's population group, everything similar to what I would need? Right? If not, my confidence in the applicability of the results comes down. Are the results consistent across the trials for that outcome? If not, could they explain it satisfactorily in a meta-analysis? Or if they use random effects model, then I know it's not a precise result. So my confidence in the consistency of the results comes down. Are the results precise? Can we be sure that the minimum important difference is there? Or is it only statistical significance? What is the lower level of the confidence interval? Is it likely to be useful? And also, do we have enough numbers? So there's a rule. If you have 400 events in total, then that's an adequate sample size. 400 people died in both the arms put together. That is enough. Or you must have at least 2,000, 3,000 patients in each arm. Then you can say number is adequate. Anything less than that, you can't be sure. And finally, are you sure you've got all the studies? So based on these criteria, once you've decided which outcomes are important for you and done the meta-analysis, for each outcome, you start grading the outcome. Right? And the way you grade it is, if you're using randomized trials, they consider to be high certainty evidence. On any one of these criteria, if you have doubts, you can downgrade your confidence in that result by 1 level or 2 levels. From high, it can come down to moderate. From moderate, it can come down to low or to very low. That's how you will downgrade your confidence in the result based on your judgments. Observations like cohort studies are considered to be low certainty because of potential selection bias. And they can be even downgraded further if they're done badly. But if you don't downgrade for methodology reasons, you can consider increasing your confidence in the result, provided they have a very large magnitude of effect. Observational study, but the effect estimate is so powerful that even if there was a little bit of selection bias, it's not going to change the result. So even though it's an observational study, I can increase my confidence in the result. Or there were a lot of confounders, but if the confounders are not there, I would have got an even better result favoring the intervention. Or across the studies, I see a dose response gradient. Higher dose, bad outcome, or better outcome, consistently across all these studies. They can be reasons why you can upgrade evidence from an observational study. So you finally then end up with 4 grades of certainty, or they call it quality, now it's certainty. High certainty, we are very confident that this is the true effect, right? And no point doing further research on this because it's not going to change anything. Moderate confidence is, we have slight doubt because of this reason, things could change a bit. Low confidence is very limited confidence in the result because of these reasons, right? And further research likely could change it. And very low certainty means we don't know. So it's a terminology we will say, this will do. Primaquine 14 days will reduce relapse rates. Or if it's moderate, it probably will. Or it may. Or evidence is very uncertain. We don't know. Right? So this is the forest plot. This is the summary of findings table for one comparison. 5 days is 14 days of primaquine. For parasitemia, detected more and follow-up was between 3 to 6 months. If you gave 14 days of primaquine, 21 per 1,000 relapses you get. If you gave 5 days, there'll be 183 more relapses per 1,000, from 49 more to 742 more, based on a relative risk of 10.05, 2.82 to 35.86. That is in favor of primaquine. It only came from 2 studies with not many patients, but there were and they were downgraded. Our confidence is downgraded for one reason. It come down to moderate. Okay, it should have been high, but it's come down to moderate. And there are footnotes explaining these. None of the adverse events, there were no major adverse events that they reported. So the footnotes will tell you that the 3 studies which came, it also says data from a third trial were not pooled due to substantial heterogeneity within the trial. It caused a lot of heterogeneity. And this trial was at risk of selection and detection bias. And the trial authors reported the lack of significant difference in recurrence over 15 months. See, their sample size assumption was there'd be a huge difference. They found no difference. And they say it's most likely due to non-adherence due to unsupervised treatment. So we didn't pool that in the meta-analysis. But we're telling you that this study is also there. From unbiased studies, this is our estimated effect. No serious study limitations, no serious inconsistency. Although there was I-square around 53, there was a disagreement in how effective primaquine is, not that it went the other way. So we are not worried about that. But they said there's serious indirectness. None of these studies included children, right? So we need more direct evidence on 14 days versus 5 in children. So some uncertainty regarding children, we downgraded by 1. But if you're interested only in adults, then it's high certainty evidence. So if you describe this, people can then understand what it means. Okay. Now, does it make a difference? So what should happen is a policymaker should take a look at all of this and then consider balance of benefits, harms, costs, burdens, preference, and recommend using or not using. So if it's a strong recommendation, it means we believe there'll be no problem, everybody will take it. Conditional recommendation means some people may find it difficult to take, either costs, side effects, availability, whatever it is. And what is the confidence in the result? So any well-written policy document will say, give you the numerical data and say, strong recommendation, high certainty evidence, or strong recommendation, moderate certainty evidence, or conditional recommendation, high, moderate, whatever. These 2 will be there. Now, as far as India was concerned, we approached the ICMR and they helped us to disseminate the results of the EU, and it changed our policy. Within a few months, the policy changed, and even the textbooks changed. But we didn't find any reference in the policy to the review. They only pointed to the WHO document. So we looked at the WHO document. And here it very clearly says, strong recommendation, high certainty evidence, 14 days primaquine. This is an update of the review. And it gives you kind of a balanced policy, the trade-offs, quality of evidence, recommendations, strong recommendation, and gives you the numbers. This is from our reviews for the summary of findings table, and they quote the reference. So you can go and read the review to see what the thing is. So this is the full cycle of evidence-informed healthcare, from framing the question to getting all the results, pooling it, and getting it into a policy document. Quite a laborious process. It's not easy, but worth thinking about this and worth starting to read more and more systematic reviews to try and understand what they mean. The Cochrane library has got quite a few reviews in neonatology, and many of them are open access. You should read them. I'm sure you have been told about the Equator Network's reporting guidelines, and you also probably know about the PRISMA statement for systematic reviews. There's also now a PRISMA for protocols, how to write your protocol, right? So these are things that you should look at. And if you want to assess how good an section by section by section. Okay. And there's a tool for assessing risk of bias in non-randomized studies. And this is the Grade Pro website. You can access it, log in, and use it for non-Cochrane reviews as well. This also got a handbook on how to grade and things. Grade Pro. I'll end you with this picture. This is Ian Chalmers. When he retired, he was knighted in the year 2005. He became Sir Ian Chalmers. We didn't know that. So when we met in one of our colloquia, he said, listen, I'm retiring. I don't have a picture of you. Can you give me a picture? So all of us sent pictures to him, and we hang with him in the National Portrait Gallery. Because he said, This is a collaboration. So he says good research requires collaboration, not competition. So I started off by saying research is meant to be a sacred activity. It's been corrupted, but hopefully in your lifetime, you'll rediscover some of the truth as you started off. If you have any questions, you can write to me, email me, prathaptharyan@gmail.com, because I think you need to go for lunch. Okay, I'm happy to answer questions, anything you want. And if you want the presentation, you ask him, I'm happy to give it. Because we all stand on the shoulders of giants, no? Take it. Okay.